Hey everybody. Okay, so our next lecture, I'm going to go ahead and screen share, is about health and reproductive justice. This is going to be a series of lectures because there's a lot to cover here and I do not want to put it all in one and make you all crazy. So we're going to go through here and we're going to start with health and wellness, okay? So we're going to talk about equity, which I'm going to get more into when we get into the equity and healthcare conversation. But before we get into that, we're going to talk a little bit about some of the other key concepts of this chapter. So androcentrism is male-centeredness. So it's talking about the fact that the male body is considered the bodily norm, specifically white male bodies. And it affects research on medical ailments and treatments because they test it on specific social norms as opposed to testing it on a wide variety of people. And that can come up with issues when you test things on specifically one kind of hormone levels, for instance, and it can interplay with certain medications, things of that nature. When you exclude women from the conversation, you exclude a lot of research possibilities and possibilities for problems to arise out of these treatments and ailments that are not tested on a specific part of the population. Insurance companies risk assessments and female fertility. So like when insurance companies start to really ask for testing or start to really want to engage with this particular type of treatment for a specific type of medical function, they assess when they're doing or getting female participants, whether or not their fertility might be involved, because they don't want lawsuits about a loss of fertility. But they're not so much worried about that in males. So worry about that more with females, because there is the social assumption, again, that females' reproductive capabilities define what it means to be woman. And that's not always the case, but it's still part of society's expectations. More money is spent on diseases that are more likely to affect men. There's a medicalization process, which is the process whereby normal functions of the body come to be seen as indicative of disease, right? So female reproductive stages and problematic diagnostics. So when we talk about female reproductive stages, we're talking about that like puberty level, we're talking about reproductive age, we're talking about the start of menstruation, then we're talking about reproductive ages, then we're talking about menopause, and when we put them into indicative like patterns like that don't always happen like they don't always happen in this followed like this age in this bracket for every woman it's a little different, and the symptoms they have when they go into menopause are a little different. The symptoms they have while they're pregnant are a little different. The symptoms they have while they're menstruating are a little different, and because of that we end up diagnosing a whole bunch of things that are just might be just part of the human form and the difference in how humans are shaped and made. But it supports this business of medical technologies, right? It supports this idea that if there's a problem, we can make money on providing a fix for it. So if we continue to make problems, then we continue to provide fixes, right? Stereotyping happens within this. So within medical and health fields, so you're going to see a lot of gender and ethnic profiling. So you're going to see a lot of things like with gender, you're going to see a lot of pain differentials where they don't think women can handle pain, so they don't take their pain seriously. You're going to see a lot of things like when it comes to female, when it comes to female ailments, you're going to see a lot more inclination to blame those on mental health aspects than you do with men. Transversely, you're going to ignore a lot of mental health issues that come down with men because they're going to assume those ailments are physical and not mental. And when it comes to racial profiling or ethnic profiling within health and wellness, there's massive amounts of documentation and research done on the fact that consistently people of color are not believed. They have incredibly toxic and racist experiences within the medical field. It's created an entire community to have, and we're going to talk about kind of the harms that have happened here in a later bit, but And it's caused a lot of community distrust of the medical field, and rightfully so. So we'll get into that a little bit more as we get into some of these other sections. There's differential treatment and provider bias, and that's going to come due to economic status. It's going to be due to your gender status. It's going to be due to your racial status. It's going to be due to any of your identities or the combination of multiple of those. Trans healthcare really varies. You do have some trans affirming healthcare, but that is rare at this point, and there is still a lot of work to be done when it comes to trans inclusive care. Corporate responsibility, so see environmental or corporate related issues, and the equity section, we'll get into that in just a bit. All right, so let's move on. We're going to talk about infectious disease for a little bit. HIV and AIDS particularly. There's a globalization aspect to HIV and AIDS where for a long time we thought it was a Western problem, but as with anything in a globalized society, you're going to see infectious disease spread. We saw that with COVID. You're going to continue to see that with any kind of infectious disease. HIV is the leading cause of death of women of reproductive age in low and middle income countries, which is a big deal, right? Like that's still very, very high rates of infection, non-consensual sterilization, and the HIV crisis. So especially during the height of the HIV crisis, it's a little less now because there has been a lot of outcry about it, but it still happens in a lot of these lower or middle income countries. In order to stop the spread, there has been a justification for non-consensual sterilization of women who are HIV positive, so that they cannot have kids and pass it to the next generation. However, with new medical supports, there are medical technologies to allow for the suppression of the HIV virus and the ability to do that. Now, whether or not those are accessible in those countries or in those areas, again, ties into this. But no matter what, there's never a right answer for non-consensually sterilizing anyone, period. Full stop. Currently in the US, 80% of women contract HIV through heterosexual contact. So for a long time, this was considered the gay disease. This is something that needs to be brought up because that's not the case, right? Like any other STD, it is a risk factor for anyone that is within or engaging in sexual interaction. And the fact that 87% of the women that are contracting HIV in this country are currently contracting it through heterosexual contact, again, denotes the fact that this is not a gay disease. This is an STD, just like several of the other ones, and it is permitted through sexual contact. And since sexual contact is primarily still heterosexual in this country, it would make sense that primarily heterosexual contact is the way in which women are gaining HIV. This disproportionately affects Black women, and socioeconomic status does play a factor in that as well. And HIV prevention and education is very rare in low socioeconomic status places. It's very rare in rural areas. It's very rare in the places that are more effective. I talked a little bit already about the HIV treatments, and then I want to talk about STDs more broadly. Services in clinic affect federal, how services of clinics affect federal and international aid. So if a lot of the clinics that treat things of this nature, that are the places where you can go to get testing, or the places where you can go to get treatments, are also places that deal with reproductive justice and reproductive medicine and care. And so due to federal funding and international funding laws, there's a lot of problems with being able to get the medicines to who needs them to be able to provide the services, because you can't provide services for anything related to abortion and provide services for anything and get federal funding for any of these other measures. And so there becomes this hole in federal and international aid where reproductive capabilities are limited, and our ability to access them gets more and more difficult for people. The Trump era expanded the limitations on female-related reproductive health care. This impacted the care and aid of multiple international programs. Religion tied into these limitations, it always does. there is this idea specifically in Christian dominated circles and activism circles that their particular ideology should be expressed through law. And because that is still the dominant religion in the US, it is still happening on a regular basis that those particular ideologies then come forth in laws because they are considered their morality. And so their moralities they want as part of their laws. Male partners impact health of female partners when it comes to STD because they're predominantly females are the survivors as a whole of sexual violence are women, which can be also a source of getting STDs. There's a lack of decision, the power of decision making when it comes to males wearing condoms, and a lack of decision to visit of the males visiting a prostitute or having sexual interactions with other people while also having sexual interactions with it. That is not to say that women are not also the cause or do not do these things. There is just a lack of power and consent, and the power and generally flows into the male's hands in our current societal structure. All right, so we're going to equity of care real quick, and then I'll probably pause it and we'll start another one. There's inequitable access and care, and that just becomes their job in relation to your insurance. So a lot of jobs are temporary or part-time and do not carry insurance. A lot of insurance plans are unaffordable. There's a lot of issues when it comes to how job-related insurance pans out in the US. The location of the physical hospitals and or care sites to individuals can be very inaccessible to those who don't have vehicles, who don't live in walking distance, who don't have money for public transit, or there's not public transit where you are, or maybe the doctor here in a rural area is incredibly far away. All of those things can create obstacles to care. And then there's discrimination by providers. And that can be on a number of different biases. Differentials based on insurance coverage and socioeconomic status. So there's several different factors that that will impact how you have or if you have insurance. And some of those are whether or not you have coverage through your job. Some of them are your socioeconomic status, and that will impact. Some of those will be those biases by providers. So if you have no insurance or less insurance, or on state-funded insurance or federally funded insurance, you're less likely to get adequate care when you go into hospitals. When you have insurance, there's definitely a differential in your overall health and well-being. Having insurance gives you more access to preventative care, and preventative care allows you to stay healthy for longer. There's a disproportionate cost for women in healthcare. And was one of the reasons why ACA, which is the Affordable Care Act, which we'll get into in a second, was necessary. And that's because we consider reproductive health or reproduction in and of itself a pre-existing condition. And so all women in the, we have made birthing so expensive that all women in the age bracket for reproduction are considered having a pre-existing condition of the possibility of birth, which sounds a little absurd because it is a little absurd. But that is how insurance are seeing that, and they're allowed to do it that way. Up until the ACA, which we'll talk about in just a second. Health insurance coverage directly results to better health, which we already talked about. Dependent status and the relationship to healthcare coverage. So a dependent, before the ACA, a dependent could be on medical insurance until they were 18. At 18, they had to find their own, unless they were in college, I think, which sometimes covered it depending on the plan, but those plans are like way out of reach for most people. And the ACA changed that to 26. Healthy alternatives to food aren't available for a lot of people. And part of accessing better health is being able to access fresh fruits and vegetables and have the economic capability of being able to do that. But there are lots of places, especially in very in urban cities where getting fresh fruit or vegetables is not as accessible. And what we call those are food deserts. Those are the areas in which fresh food are really hard to come by, or people are shopping at mini marts or like corner stores or what have you, where those places are inflating the prices and not necessarily having the best variety of food. Also, it depends on your economic status, whether even if you have the access to the food, doesn't mean you have the economic access to the food. Environmental justice is also a main key component of equity in healthcare because predominantly like women and lower class and lower economic status individuals reap the injustice when it comes to environmental harm. And so this comes down to things like toxins in the water. This comes down to harms in the food products and things of that nature. Climate change also impacts healthcare by impacting the food waste, the natural traditional ways of humans, that the kinds of foods they can get, the amount of travel the foods have to get to come to you, the amount of preservatives they have to put in the foods in order to make it to you. All of these things are impacted by climate change and impacted by the way in which we can be healthy individuals. The medical industrial complex is an incredible lobbying force, and it lobbies for things that are not in our necessarily interest, because it's a business and it wants to run a business like it wants to run a business, and it wants to make as much profit as humanly possible. So even if it is creating ecological disasters or creating more medical problems with its medical solutions, as long as it keeps making money off the solutions on the problems it's creating, it's going to continue to do so. So, and that's just like any other big industrial complex, and they have a lot of ability to sway laws and sway what is fair, what is medically necessary, what is a pre-existing condition, all of those things, because they're an entire entity that has billions and billions of dollars to throw into lobbying in a way that the average citizen does not. Globalization also impacts healthcare in the way that, again, we talked kind of about access when we talk about HIV and AIDS crisis. The same happens for most crises, right? You're going to see, you've seen an exploding amount of COVID cases in lower income countries because it doesn't have access. You're going to see a wider range of vaccine distribution depending on countries' access to those things. And that impacts whether or not globally we can get and maintain certain kinds of healthcare concerns. We're going to talk about the Affordable Care Act, which is also called Obamacare, which is also called the ACA. It's called a lot of different things. But what this really did was, if you're receiving federal funds, no discrimination on the bias of gender, national orientation, ethnicity, age, or disability was capable in medical insurance coverage. It also got rid of this gender rating, so you could not essentially rate someone more at risk because of their gender of things like pregnancy. Like you couldn't add that as a pre-existing condition because that was something that was biologically a possibility with their body. Preventative care and mental health coverage became part of insurance plans and something that had to be covered. Dependents could be covered on their caregivers until they're 26. In Trump area, the funding decreased for this particular kind of insurance, and they consistently have Supreme Court battles trying to upend it. Unfortunately, well, fortunately, all of those things were upheld in court, even with the court system being predominantly conservative. However, the funding decreases were still allowed. All right, so let's pop back out of here. We'll get into female anatomical health in the next section, and then we'll get into some of the other nuances of this, and then we'll start in on reproductive justice, which is a longer section. All right.